Hello everyone and welcome to our module on glomerular disease principles. So before we can talk about diseases of the glomerulus, we need to talk about what the glomerulus is supposed to do under normal conditions. So the glomerulus's job is to allow ultrafiltrate into Bowman space. So what is ultrafiltrate? That's water, electrolyte, glucose, and amino acids, all the things that the kidney wants to allow into the nephron so that it can then control how much it absorbs or excretes. Importantly, though, the glomerulus wants to prevent the filtration of most proteins and prevent the filtration of red blood cells. So when you have a sick glomerulus, you get protein and blood in the urine, and that's called proteinuria and hematuria. In order for things to move from the glomerular capillary into Bowman space, they have to pass through the glomerular filtration barrier. And it's very important that you understand the three components of the filtration barrier because the pathology in all these diseases involves these three components. So if we draw some blood moving through the capillary here, if it wants to send parts of the blood into Bowman space, it must go this way through all three of these layers. So the first layer is the endothelium of the capillary. The second layer is the capillary basement membrane. And then the third layer are these cells called podocytes. And it's very important to know that the podocytes are also called the epithelium. So you will hear in glomerular diseases about problems with the endothelium, and that's the capillary endothelium, and the epithelium. The epithelium means the podocytes on the other side of the basement membrane from the capillary. So let's talk about each of these components of the filtration barrier in more detail. So the capillary endothelium is fenestrated, and that means it has small openings, and only small molecules about 40 nanometers in size can pass through. This is going to repel red cells, white cells, and platelets, and it's the first barrier to filtration. So essentially, the capillary endothelium is going to keep out most of the cells inside the plasma. The next layer is the basement membrane, and one of the most important features of this layer is that it is made up of negatively charged molecules. It contains type 4 collagen that is wrapped in a substance called heparan sulfate, which is negatively charged. As a result, the basement membrane repels negatively charged molecules like albumin. It also serves as a size barrier and only allows small molecules to pass through. And then finally, the third barrier are the podocytes, which, as I said before, are called epithelial cells. And they have these long processes called foot processes that wrap around the capillaries. And the slits between the foot processes act as a filter. And this is a further size barrier, only allowing very small molecules to get through. So albumin is the major protein in the blood. Recall that it's responsible for most of the oncotic pressure of the plasma, and it's a small protein, about 3.6 nanometers in size. So it can fit through all the size barriers. The reason it can't get through the filtration barrier is because it's negatively charged, and it's repelled by the glomerular basement membrane. I made this point before, but I'm just mentioning it again because albumin getting into the urine is responsible for much of the pathology in glomerular diseases. So now let's talk about the different types of things that happen to patients with glomerular diseases. On a fundamental level, all these diseases cause breakdown of the filtration barrier. So things that shouldn't be in the urine get there, like red cells and protein, especially albumin. So hematuria, or red blood cells in the urine, are a common finding in many forms of glomerular disease, and hematuria is detected by urinalysis. There are two urine tests that are used to identify the presence of red cells in the urine. The first one is the urine dipstick test. The urine dipstick test involves taking a standard urine dipstick strip and dipping it in a sample of urine. It will detect a number of substances in the urine, including the presence of heme. Heme has peroxidase activity. It will react with the strip, so the dipstick test will be heme positive if there is either hemoglobin or myoglobin in the urine. Usually when this test is positive, it means there's blood in the urine. However, it can also be positive in rhabdomyolysis when there is myoglobin in the urine. The second way to detect red cells in the urine is by microscopy. This involves taking a sample of urine and looking at it under the microscope, and red blood cells can be directly visualized. Now, hematuria has many causes, and in fact, glomerular diseases are incredibly rare. We call hematuria gross when the urine changes color, and then we call it microscopic when the urine has normal color. But if you look at it under the microscope with urinalysis, you can see evidence of red cells. Hematuria can occur after exercise in normal kidneys. We don't know why this happens, but some patients, when they exercise strenuously, will develop hematuria. And very common causes of hematuria are urinary tract infections and kidney stones. The feared cause of hematuria is bladder cancer, and then, as I said before, glomerular diseases are very rare. But hematuria from glomerular disease is usually easy to identify because patients will have red cell cast, which we'll talk about in a minute, and also protein in the urine. So the hallmark of bleeding from the glomerulus are red cell casts. So if you have a glomerulus here and red cells are able to squeeze through that filtration barrier because of disease, they will then be pushed into the nephron. And they will all get bunched up together inside the nephron, and this will form a cast of the red cells. So down here on the right is a picture of a red cell cast under the microscope, and as I said before, this is the hallmark of glomerular bleeding. Other things you may see are dysmorphic red blood cells. These are red blood cells that have an abnormal shape. And just like the mechanism of cast, this happens because you're squeezing them through the filtration barrier and the nephron. You can also see acanthocytes. These are red blood cells that have a spiked cell membrane. So instead of being a nice circle, they sort of have a spiky cell membrane looking sort of something like this. And then in addition to the red cell findings, people with glomerular bleeding often have proteinuria. They can describe their urine as having a red, smoky brown color or Coca-Cola color. And importantly, clots are generally not seen. People who have clots in their urine have heavy bleeding. That's usually from the bladder. It's usually seen with kidney stones or bladder tumors. So proteinuria is another hallmark of glomerular disease, and there's a couple of ways we can diagnose proteinuria. The first is, again, to use that urine dipstick. It has squares on it that will change color, indicating the amount of protein. And it primarily detects albumin, which is good for glomerular disease, but you should know this because in other pathology, where the protein involved is not albumin, the urine dipstick is not so good at picking it up. We describe the urine dipstick proteinuria as 1 plus, 2 plus, 3 plus, or 4 plus to say how much protein there is. So glomerular diseases often have 4 plus protein, meaning there's a lot of protein in the urine. And the problem with the urine dipstick is it's affected by urine concentration. So if you're dehydrated, the concentration of the small normal amount of protein in the urine can go up and you can get a false positive. Another way to test for proteinuria is to do something called the urine protein to creatinine ratio. This is also called a spot urine. So you take the first or second morning urine sample after avoiding exercise and you test for the amount of protein and creatinine in the sample. And a normal ratio is less than 0.2. And this is less influenced by hydration status, so some people find it to be more accurate. And then the ultimate way to measure protein in the urine is to do a 24-hour urine collection. So you ask the patient to carry around a bucket and to urinate in each time they go. This is the gold standard for evaluating protein excretion by the kidneys. It gives you an actual number of grams per day of protein excretion, and normal is less than 150. The problem is it's very cumbersome for patients because they have to carry this bucket around and keep it in the refrigerator when they're not going to the bathroom. And often patients forget and miss a void, and therefore you get an error in the collection. So glomerular diseases generally occur along a spectrum. On one end of the spectrum are the nephritic syndromes, and these are glomerular diseases where patients get red blood cell casts in the urine, mild proteinuria, and they develop renal failure. On the other end of the spectrum is the nephrotic syndrome. This is where patients have massive proteinuria and hyperlipidemia. We're going to talk about more of these in detail. Essentially, in the nephrotic syndrome, patients are largely losing albumin. That's the main source of the problem, but they're not losing red cells in the urine. In the nephritic syndrome, they're losing both protein and red cells, and also the kidneys are starting to shut down to give renal failure. So we'll talk about the nephrotic syndrome first. This is where the filtration barrier to protein is lost, but the red blood cell filtration barrier remains intact. These patients have massive proteinuria. It will be 4 plus on a dipstick and more than 3.5 grams per day if you do a 24-hour urine collection. And the loss of all that protein and albumin triggers a cascade of pathology that results in all the symptoms of the nephrotic syndrome. So this is our map of the sequence of events that leads to the symptoms of nephrotic syndrome. So let's go through it in detail. So the whole sequence of events begins with the loss of protein. And the first thing this is going to do is spill protein into the urine and give you proteinuria, which patients often describe as seeing a frothiness to the urine. Now, the loss of protein will lead to the loss of albumin. And when you have low albumin, you get low plasma oncotic pressure. This means that fluid will leak out into the interstitium, and that will cause edema. You also get edema from another mechanism. The loss of plasmic oncotic pressure leads to a reduction in extracellular volume and a reduction in glomerular filtration rate. This is going to ramp up the renin-angiotensin-aldosterone system and lead to sodium and water retention. So that is also going to contribute to the edema. There are two mechanisms by which you get edema in the nephrotic syndrome. Now, when you begin to lose all that albumin, the liver tries to become active to replace it, but it can't keep up with the losses. What you're going to see in the patient's blood tests as a result of all this liver metabolic activity is hyperlipidemia. Patients with the nephrotic syndrome have very high levels of total cholesterol and LDL. Interestingly, their HDL levels are usually not elevated. It's mostly LDL, and that's seen in the total cholesterol. Now, all this lipid in the bloodstream is going to lead to two findings in the urine you should know about called fatty casts and oval fat bodies. In addition, because you're losing protein, you can lose antithrombin 3, which is a clotting factor, and this predisposes patients to thrombosis. So the nephrotic syndrome is a hypercoagulable state, and they love to ask you on your boards about patients with nephrotic syndrome who then get pulmonary embolisms. And the mechanism is the loss of antithrombin 3 in the urine. And then lastly, other proteins that you lose in the urine are immunoglobulins, and this predisposes patients to infections. So some patients with nephrotic syndrome are at increased risk of infections. Make sure you understand this map and how all these things work together. Let me give you a little more detail about the urine in patients with nephrotic syndrome. You may see lipids in the urine. Now, they can be trapped in casts, and these are called fatty casts. They also can be enclosed by a plasma membrane of degenerated epithelial cells, and these are called oval fat bodies. And if you look at these under polarized light, the fat droplets have an appearance of a Maltese cross. So if you heard a description of urine as showing fatty casts, oval fat bodies, or Maltese cross, they are talking about nephrotic urine. So here's the classic presentation of a patient with the nephrotic syndrome. They will complain of frothy urine from the protein in the urine. They will have swelling in their ankles. They will also complain of swelling around their eyes. This is called periorbital edema. The tissue around the eyes is very loosely attached to the underlying tissue, and it puffs out very easily, especially in states of low oncotic pressure. So periorbital edema is a classic sign of glomerular diseases. This is often mistaken for an allergic reaction, so especially on boards questions, watch for a case where the patient thinks they're having an allergy, but it's actually nephrotic syndrome. The serum total cholesterol will be very high, usually over 300 milligrams per deciliter. And remember, that's mostly LDL, not HDL. And there will be heavy proteinuria, which is more than 3.5 grams per day. Now we're going to talk about the nephritic syndrome. And this is when you have an inflammatory process that damages the entire glomeruli. So the filtration barrier to red blood cells and protein is lost. As a result of the glomerular damage, the glomerular filtration rate begins to fall. These patients will have renal failure. There will be red cells in the urine. They will be those dysmorphic red cells, or you may see those casts. And there will be protein in the urine, but importantly, it's less than nephrotic syndrome. Because these patients have a low GFR, they don't excrete as much protein per day as patients with the nephrotic syndrome. So these patients will have urine with protein described as less than 3.5 grams per day. That number, 3.5, is a key number. Nephritic syndrome usually has less than 3.5, and nephrotic usually has more than 3.5. So here's our map of the sequence of events in nephritic syndrome, and let's go through it in detail just like we did for nephrotic syndrome. So you lose the filtration barrier, and as a result, red cells spill into the urine, and you get all these findings over here, dysmorphic red cells and casts. In addition, the GFR begins to fall. This means that the BUN and creatinine levels will rise. It also means that patients may have oliguria. They'll have decreased urine production. Because the GFR falls, the hydrostatic pressure inside the vasculature goes up. So patients with nephritic syndrome will have hypertension, and that hydrostatic pressure will drive fluid into the extracellular space, and you will get edema. Another mechanism by which you get edema is that there's proteinuria from the protein loss in the urine, so therefore you lose the oncotic pressure, and this also triggers edema. So there's two ways you get edema in nephritic syndrome. Just like with nephrotic syndrome, make sure you understand this map because you're commonly tested on the mechanisms by which the symptoms develop in nephritic syndrome. So the classic presentation of a patient with nephritic syndrome is for a patient to complain of dark urine from all those red cells. They'll complain of swelling and edema. They will often have fatigue as a symptom of the uremia, and then they'll have proteinuria, but it's less than 3.5 grams per day. The last thing I'm going to discuss in this module are different techniques of microscopy. So most glomerular diseases are diagnosed by doing a kidney biopsy. And once you biopsy the kidney, you have to look at it under the microscope to figure out which disease you have. And there are three techniques we use to discern the different glomerular diseases. The first is light microscopy, and that simply means using a basic stain and looking at it under the light microscope. And you can see magnifications up to 2000x this way. And here I've shown a picture of a normal glomerulus. The second thing you can do is treat the sample with antibodies that light up under immunofluorescence. And this is a way to look for specific proteins or antigens. And this is called immunostaining. And this is a picture here of a glomerulus that's been stained with immunofluorescence. And then the last thing you can do is use something called an electron microscope. So an electron microscope uses electrons instead of photons to take very high magnification pictures of structures. These can take pictures up to 10 million times what you normally see with your eye. And this is the way we look at very detailed structures like basement membranes and podocytes. And this is a picture up here of a normal basement membrane and a set of podocytes. So make sure you understand the difference between these three techniques because all the glomerular diseases have different findings, and some of them are light microscopy findings, some are immunofluorescence, and some are electron microscopy. So that concludes our module on Intro to Glomerular Diseases. In the specific modules on nephritic and nephrotic syndrome, I'll talk about the different entities that cause those two conditions.